This program is brought to you by Emory University.
Good morning, everyone. Welcome to Heart and Vascular Grand Rounds. This morning we're going to have all the mysteries of afib ablation removed for us and explained, and because this is sort of a challenging and a very evolving area, as is a lot of afib. Afib's been an area that sort of went quiet for a long time, and then over the last several years there's been a lot of advances, a lot of new challenges. And our speaker today is our own Dr. El-Chami, who did his training here. And is an associate professor in the division, if I remember correctly, and practices primarily out of Midtown. So, Mikhael, explain it all to us.
Thank you, and good morning. So I'll be focusing during this talk about the outcomes of AFib ablation, and half of the talk will be about heart failure patients because there's a lot of new data about AFib ablation in heart failure patients. It's my disclosure slide. So the outline of my discussion today, we will start with a brief summary of atrial fibrillation epidemiology, then review all the randomized trial or most of the randomized trial comparing AFib ablation versus medical therapy, then focus on the relationship between atrial fibrillation and heart failure, and end by reviewing the outcomes of AFib ablation in patients with left ventricular dysfunction and heart failure. Atrial fibrillation is the most common arrhythmia that we encounter in clinical practice. And right now, there's around 6 million patients with AFib, and this number is expected to double, reaching 12 million Americans with atrial fibrillation by 2030. And the Framingham Heart Study will allow us to determine the lifetime risk of developing atrial fibrillation. So if you look at healthy subjects enrolled in the Framingham Heart Study, and if you reach the age 40 without AFib, but you live till you're 90, your odds of having atrial fibrillation is very high. So almost 1 in 4 patients will eventually develop atrial fibrillation as if they live long enough. And the reason this is important is that atrial fibrillation is not a benign problem. It is associated with a 5-fold higher risk of stroke and 2-fold higher risk of death. And in this elegant sub-study from the RELY trial is a trial that compared Pradaxa to warfarin in patients with AFib. The authors attempted to look at the causes of death in atrial fibrillation. And out of 18,000 patients, there were 1,371 deaths. And as you would expect in this population, the predominant cause of death is cardiovascular death. While one would think that embolic event and strokes would account for most of these causes, stroke is only responsible for 7% of all cause of death. And really, progression to heart failure and sudden cardiac death is the main cause of death in patients with atrial fibrillation and not stroke. Therefore, throughout the years, there's been attempts to suppress or treat atrial fibrillation. But if you look at these 2 landmark trials that were published simultaneously several years ago in the New England Journal of Medicine, you can see that whether you treat AFib with a rate control strategy or a rhythm control strategy, there's really no significant difference in outcomes in terms of mortality, stroke, and heart failure progression. But if you look at this subgroup analysis from the AFFIRM trial, you can see that if you end up the trial in normal sinus rhythm, you have higher survival than if you end up in atrial fibrillation. Obviously, this is a subgroup analysis. But if you end up on antiarrhythmic drugs, your mortality is much higher. So maybe that normal sinus rhythm might improve survival, but its effect is nullified by the presence of antiarrhythmic drugs. And therefore, the role of ablation has evolved throughout the years to potentially replace antiarrhythmic drugs. And if atrial fibrillation could provide a higher success in maintaining normal sinus rhythm and reduce or eliminate the need for antiarrhythmic drugs, maybe the outcome will change. And Faisal Merchant always tells the fellow, if you can draw the mechanism of an arrhythmia on a napkin, then you would know how to ablate it. Unfortunately, the mechanism of AFib has been elusive throughout the years. And there's been multiple proposed mechanisms. Scherf in 1947 came up with the focal theory, 50 years before the seminal paper by Michel Essaguer. And then the multiple wavelet reentry is the theory that was quoted most in the literature and was described by Mo and LSC in the 50s or 60s. And several years ago, Narayan described the rotor, the mother rotor that triggers atrial fibrillation, and the original studies were encouraging, but no one was able to reproduce this finding in terms of ablating one area in the atria and eliminating atrial fibrillation. Later on, Waldo described multiple smaller rotors that could trigger atrial fibrillation. And several investigators have shown that transmural dispersion of repolarization, difference in the repolarization between the epicardium and endocardium, help maintain atrial fibrillation. But the only theory that have stood the test of time was the venous trigger mechanism. This was published by the Bordeaux group from Michel Essaguer 20 years ago now, looking at identifying triggers for atrial fibrillation. And if you look at this number, the 60% success rate that I will show you later really hasn't changed much for the last 20 years. But these investigators were able to identify triggers for AFib coming from the pulmonary vein or other venous structure, the superior vena cava, the coronary sinus, and in some instances later, the ligament of Marshall was a potential trigger for atrial fibrillation. Since that time, isolating the pulmonary vein has become the cornerstone of atrial fibrillation. And this is from the guidelines that irrespective of the approach you have to use to treat AFib with an ablation procedure, you have to isolate the pulmonary veins. And you can see a lesion set in that form, encircling the pulmonary veins, or doing extra lines. This is, for example, an example of isolating the posterior wall. The posterior wall has the same embryologic background as the pulmonary vein, and some people in difficult cases attempt to isolate not only the veins, but the posterior wall. And this is an example of targeting vagal ganglia to ablate AFib. But irrespective of the method that people choose, the first thing that we do during ablation of atrial fibrillation is isolate the pulmonary veins. So let's review some of the data on ablation. And we'll only review the randomized control trials. There's so many different trials, but we'll only review the ablation versus antiarrhythmic drugs. And what we would look at first is ablation as first-line therapy, meaning these patients were never tried on antiarrhythmic drugs. You randomize them to ablation versus drug therapy. And then the next set of data is ablation after failure of antiarrhythmic drugs. So it's a little bit different population. And the first ablation trial, or randomized trial, was published in 2005 by the Cleveland Clinic Group, enrolling 30 patients in each arm, so it was a small study. But then later on, 2012, this European study looked at RF ablation as initial therapy in paroxysmal atrial fibrillation. And if you see the patient characteristics, they were young, they had really normal ejection fraction, and the left atrial size was acceptable, was near normal as compared to the trial I will show you in heart failure patients. But in this trial, there was 36% crossover to ablation, and I think this is a problem with all intervention trial, ablation, PCI, what have you. And this number, and even higher number, will show up in the latest trial that I will discuss during the course of this talk. And if you look at the outcomes at 2 years, freedom from AFib was better with ablation. But if you follow these patients throughout the years, their AFib burden is not different until the 2-year period. So the trial was labeled as negative. And even if you look at the quality of life improvement, being in sinus rhythm improved quality of life, but it doesn't matter if you achieve normal sinus rhythm with antiarrhythmic drug or with an ablation procedure. So the main importance of these trials is that normal sinus rhythm might improve quality of life, but you might achieve it with both ablation or antiarrhythmic drugs. The second larger trial, little bit smaller trial, was published in JAMA in 2014. And again, look at the numbers, 66 versus 61. Healthy subjects, mean age is 55. And if you look at the EF is normal, the left atrial size is near normal, and the mean CHAD score is 0.5 and 0.7. So this really subjects with no significant comorbidities. And the recurrent theme of these trials, the high rate of crossover. More than 40% crossed over to ablation, and 10 underwent re-ablation. And this was a small study, 66 patients versus 61 patients in the drug arm. And if you look at the ablation versus antiarrhythmic drug, it was associated with a lower AF recurrence, 47 versus 59. So that gives you a success rate of 53%. So the success rate is mediocre, but it's better than antiarrhythmic drugs. And remember, these patients were never tried on any antiarrhythmic drug before. So let's examine the second set of ablation trial, is what happens if you refer these patients for ablation after they fail an antiarrhythmic drugs, which is the way most of us practice today. And this is the Thermocool AFib trial published in JAMA in 2010, and looking at the outcome of ablation versus antiarrhythmic drugs. There was about 12% redo procedure. But if you look at the success of an ablation, is 66% versus 16% in antiarrhythmic drugs. Remember, the difference here is that these patients have tried the medication has failed, so what happened in the first 3 months, they were either shifted to a new antiarrhythmic, or the dose was titrated, or they went for an ablation. And I think that's where we see the difference in terms of effectiveness of ablation versus antiarrhythmic drugs. Obviously, 66% is not a great number, but is way better than antiarrhythmic drugs. And most of the trial I've showed you for now have focused on the technology of radiofrequency ablation. And the way we ablate around the vein with a radiofrequency catheter is point-by-point ablation. So we surround the vein with ablation until we electrically isolate the vein. But more recently, the cryoballoon technology, which I think Dr. Langberg was one of the first who patented this technology, is using a balloon to occlude the pulmonary vein and deliver a cryoablation to isolate the vein. And this is an example of what we do in a case. This is the cryoballoon here, and you inject dye, make sure that the vein is occluded. You have a catheter here that records electrical signal for the vein, and while you come on ablation, some people might have some dizzy spells looking at this, but look at the electrogram in the 2 or 3 here. You see an electrogram that has 2 components, and as you come on the freezing, these 2 components will start to separate, and the second component is the pulmonary vein potential, and so you see here the separation, and then it will disappear here, comes back, and then it goes away here. So that's how we isolate the vein. Most of us, I think, here have adopted the cryo-isolation, especially for paroxysmal atrial fibrillation, instead of doing a point-by-point ablation with a radiofrequency catheter. So the first data on the cryoballoon came around 5 years ago. And again, this was ablation after failure of antiarrhythmic drugs. And look at the crossover. So it took 3 months to optimize the antiarrhythmic drug, and there was a blanking period. For all ablation trial, we have the 3-month blanking period because of inflammation and irritation after an ablation. You can have early recurrence. But then if you fail the drug, the odds of that drug working or a different drug working is very low, and there's 79% crossover. All these analyses were done as intention to treat, and you can see that similar to what we've seen in the first trial, the Thermocool trial, the success rate is close to 70%, 66 and 69%, and the success rate of a drug is 7%. When they looked at the patients that crossed over, since the crossover was very high, after the crossover, the patients who underwent ablation have similar curve here as the ablation. So, and these technologies, the cryoballoon and the radiofrequency, have compared to head, and they were similar effectiveness. The success rate of the ablation was around 65%. And the only advantage I think that cryoballoon allows is shorter procedure time than a radiofrequency ablation. So now I will discuss this trial that stirred a lot of problem and controversy in the EP and cardiology literature. And I apologize, the trial has not been published yet. I heard that it was accepted in New England Journal of Medicine, but the editorial does not want to show the on-therapy arm. They just want to show the intention to treat analysis, but it should come out soon. So these slides are from the presentation during the late-breaking session in the Heart Rhythm Society meeting. So this was a prospective, unblinded, randomized controlled trial. This was a trial that took around 10 years to finish, and everyone was waiting for it. And it's comparing catheter ablation with medical therapy. You could use rate or rhythm control. This was left to the investigator. And one of the criticism of the AFib ablation trial is none of the trial looked at hard endpoint. None of them looked at mortality. None of them looked at stroke or heart failure endpoint. And this trial was designed to look at total mortality and composite of mortality, stroke, serious bleeding, and cardiac arrest. And included both paroxysmal, persistent, or permanent AFib. And these patients were sicker. They had to have an elevated CHA2DS2-VASc score to go into the trial. And there should be minimum 2-year follow-up. And as you can see, this is a large trial for AFib ablation. Obviously not if we look at coronary trials, but 2,204 trial. This is the largest ablation trial that we have, randomizing ablation therapy versus drug therapy. Around 88% followed the rhythm control, 11% followed the rate control. But look at the crossover. 27.5% crossover to ablation, and 9% crossover from ablation to drug therapy. So I think that's a major problem with all intervention trials. And if you look at these patients, they were older than the typical ablation trial. The two trials that I've showed you earlier had an age in the 50s as mean age. These were in the 60s. Third were younger than 65. Half were between 65 and 74. And 14% were older than 75. And 15% had CHF, and 34% had class 2 or 3 symptoms of heart failure. And if you look at the intention to treat analysis, and looking at the primary endpoint, death, disabling stroke, serious bleeding, or cardiac arrest, you can see that there was no benefit of ablation as compared to drug therapy. And if you look at all the primary outcome, they were negative. Death, disabling stroke, bleeding, cardiac arrest. But if you look at cardiovascular hospitalization and looking at the intention to treat analysis, there was around 18% reduction in cardiovascular hospitalization, just simply examining the intention to treat analysis. So because there were around 37% treatment crossover, 27.5% crossover from drug to ablation, and 9% crossover from ablation to drug therapy, the investigator also presented the per protocol analysis. And if you look at the ablation versus drug and look at the primary outcome, ablation with the per protocol analysis did reduce the primary outcome. It was statistically significant. And if you look at primary outcome, there was 33% reduction. All-cause mortality was reduced by 40%, and death or cardiovascular hospitalization by 17%. So as you could expect, people interpreted the trial differently. And if you look at this blogging, Cabana ablation disappoints for AFib versus drug, questions remain. This was from John Mandarola. Landmark Cabana trial confirms ablation equal to or superior to drug therapy. So you could interpret the trial the way you want it. AFib ablation outperformed drugs in Cabana trial. And obviously there was Milton Packard who wrote this editorial. Half of it was full of sarcasm. And the title was Unbelievable, Electrophysiologists Embrace Alternative Facts. And there was a lot of back and forth, like even on social media. It was really embarrassing. And these are the comments by Doug Packer. And this is his conclusion, that ablation is an acceptable treatment strategy for treating AFib patients with low adverse event rates in higher risk patients. I didn't show you the adverse events, but were really very low. In terms of tamponade was less than 1%, atrioesophageal fistula occurring 1 in 2,000. So the adverse events were low. And when he was asked, why did you look at on treatment or per protocol analysis, he said, well, you don't get benefit from a therapy if you don't get the therapy. And then Eric Kristowski, who was the discussant of the trial, said, well, the trial establishes ablation as a first-line alternative to drug therapy. It's reasonable if drug don't work, then ablation is an alternative. But I think there's some take-home points that we can take from this trial. Number one, if you look at subgroup analysis, again, this is subgroup analysis, but if you take patients that are younger than 65, there was a strong reduction in mortality, even less than 75. And if you look at the presence or absence of congestive heart failure, if you had congestive heart failure, there was a reduction in mortality. And if you had any symptomatic heart failure, there was a reduction in mortality. So what is my take on Cabana? I think if you're really talking about randomized control trial, you should analyze them based on an intention to treat analysis. Otherwise, if you remove the intention to treat analysis, you are interfering with the randomization process. So the intention to treat analysis is what we take from this trial. But even looking at the intention to treat analysis, ablation did decrease cardiovascular hospitalization. So that's something positive out of this trial. And I think ablation should be an acceptable treatment alternative when you talk about patients who fail or cannot tolerate antiarrhythmic drugs. I think most of us here, in terms of EP, we offer ablation after failure of antiarrhythmic drugs. And in the last 10 years that I've been doing this, when I counsel patients about AFib ablation, my focus is on symptoms improvement and not mortality reduction. I've never told my patient, you're gonna get an AFib ablation and therefore you will live longer or you can stop anticoagulation. Just the focus is mainly on symptom reduction rather than the mortality benefit or coming off blood thinners, for example. And speaking about symptoms, there was a symptoms improvement with Cabana. These were presented as a late breaker trial by the Duke Clinical Research Institute at the European Society of Cardiology in August. And they used multiple different specific symptoms questionnaire. And this is at baseline, the quality of life was similar between the two groups. And as you follow these patients, the quality of life does improve and it persists up to 5 years. And this is another more known overall score of quality of life with atrial fibrillation. And again, the quality of life was improved with ablation as compared to medical therapy. So if we offer ablation for symptomatic patients, then we're achieving our goal, especially if you offer it to patients who fail antiarrhythmic drugs and who have symptoms. You should not offer it to patients who have no symptoms or for the sole purpose. For example, we get some consults about, I want to have an ablation to come off blood thinners, and that's the wrong reason to undergo an ablation. So what does the guideline and the Heart Rhythm Society consensus statement say about ablation? Obviously, this is before Cabana was published. You see the word symptomatic here. So from the get-go, you have to have symptomatic AFib. And sometimes it's really difficult to quantify symptoms in AFib. And what you could do if someone has persistent atrial fibrillation is you could perform a cardioversion and see if they remain symptom-free when in sinus rhythm as compared to an ablation. Because sometimes when someone is in AFib for a while, it's become very difficult to determine whether the AFib is symptomatic or not. But at any rate, you have to approach symptomatic AF patients. And if you have paroxysmal AF and you fail medication, then ablation was given a class 1 indication. Going straight to an ablation has a lower recommendation, class 2A recommendation. And the same applied to persistent AFib, but here the recommendation goes down from class 1 to class 2A indication. If you have a long-standing persistent AF, so that's AFib for more than 1 year, then it's a class 2B, ablation is a class 2B rather than 1 or 2A. So what about indications in selected group? If you have CHF, older patient, hypertroph, younger patients, basically they get similar class 2A indication. The strange thing about the consensus statement is even for asymptomatic AFib, it used to be class 3, now it became class 2B. But I think what I want to focus on is the CHF patients, because traditionally speaking, when we first started doing AFib ablation, we shied away from these patients, because these patients have structural heart disease, they have enlarged left atrium, so the odds of an ablation working is lower than in the typical healthy patient with no structural heart disease. But atrial fibrillation and heart failure are strongly connected. 20 years ago, Eugene Braunwood, in a Shattuck lecture in New England Journal of Medicine, declared that AFib and heart failure are the two new epidemics of cardiovascular disease, because the 20 years before, coronary artery disease was the epidemic. And in 2030, as I mentioned, 12 million patients will have AFib, and more than 8 billion patients will have heart failure. And when you look at studies trying to determine the relationship between atrial fibrillation and heart failure, these studies are very limited, because you look at registries, you look at retrospective studies, and it's hard to determine what comes first, the AFib or the heart failure. But this elegant study from the Framingham Heart Study, looking at new onset AFib or heart failure between 1980 and 2012, and the reason these dates were chosen is that after the 80s, the echo became almost standard, so most people had an EF documentation. And as you see, if you have heart failure, the incidence of AFib is higher. And if you have atrial fibrillation, the incidence of heart failure with preserved and reduced ejection fraction is higher than if you have no AFib. And basically, this study showed that if you have heart failure, new onset heart failure, and you follow these patients prospectively for around 8 years, 57% of these patients develop atrial fibrillation. Even more interesting is if you have a new onset AFib and you follow these patients for 8 years, 37% develop heart failure. That's a large percentage. And in this study also, they showed that the presence of AFib and heart failure increased the mortality. So if you had heart failure and you develop AFib on top of it, your mortality is higher. So there's multiple potential links between AFib and heart failure. As I told you in a second, 1/3 or 37%, even more than 1/3, 37% of patients who have AFib eventually develop heart failure. And the most common mechanism that we quote is tachycardia-mediated cardiomyopathy. But there's some conflicting data that even if your rate is well controlled, rate irregularities could lead to depression in ejection fraction or heart failure with preserved EF. We've also recently emerged the subgroup of patients who have reversible LV dysfunction when they have AFib despite having controlled ventricular response. And we know that atrial fibrillation, patients with AFib have elevated left atrial pressure, they lose their atrial kick, and they usually could develop heart failure with preserved EF. And when you have both conditions, the treatment of these patients who have both AFib and heart failure is complicated by the fact that the relationship between AFib and heart failure contribute to a vicious cycle. For example, atrial fibrillation has been shown to leading to fibrosis of the left and right ventricle, neurohormonal activation, which could lead to heart failure. Hemodynamically, it could decrease cardiac output by rapid ventricular rate, irregular rate, loss of atrial kick, and tachycardia-related cardiomyopathy, which leads to heart failure with reduced EF. By itself could increase neurohormonal activation, lead to enlargement in left atrium, increase in left atrial pressure, and functional MR, which by itself could lead to atrial fibrillation. So often when you're faced with these two conditions in patients with heart failure, you have to treat both heart failure and atrial fibrillation. But the optimal strategy to treat AF in heart failure patients is not very clear. And the relative impact of rate and rhythm control on heart failure outcomes is difficult to study, because most of the study design of strategy trial, a strategy of maintaining sinus rhythm or rate control, is often flawed due to lack of blinding, therapy standardization, and mainly crossover between the groups. And I will show you here today whether the method of rhythm control matters in terms of altering outcomes. So this was a famous trial published in 2008 looking at rhythm control versus rate control for AFib ablation and heart failure. It's the AF-CHF trial, and randomized more than 600 patients to rate versus rhythm control. And rhythm control was mainly achieved with amiodarone. And there was no survival benefit for rate versus rhythm control. And even there was no difference in worsening of heart failure. The antiarrhythmic drug in this group did a decent job in maintaining sinus rhythm. I mean, by the end of the study, the the rate of AFib was only 30% in the rhythm control group. So the antiarrhythmic did a good job in maintaining sinus rhythm, but there was no difference in endpoint. And there was this famous editorial after this trial by Ann Curtis and Michael Kane that it's really difficult to support a primary approach of rhythm control that relies on antiarrhythmic drugs in any patient with AFib. That's based on the data that I've showed you from RACE and AFFIRM, including those with heart failure patients. So obviously, electrophysiologists saw this editorial and said, well, let's see if ablation works better in this group of patients. And this was a study from multinational study, mainly led by investigator from France and the US, looking at pulmonary vein isolation for AFib in patients with heart failure. So if you look at these patients, they all had low ejection fraction, 27 to 29%. Their left atrial diameter as compared to the earlier studies I've shown you is really different. This is 4.9 to 4.7, so at least moderate enlargement of left atrium. And the presence of paroxysmal versus persistent was almost half and half. And if you look at the freedom from AFib with and without antiarrhythmic drugs, so if at 6 months you were still on antiarrhythmic drugs, 80% remained in sinus rhythm. If you were not on antiarrhythmic drugs, 70% were in sinus rhythm. So it's an acceptable endpoint for ablation in heart failure patients. But I think the surprising results of this study showed, by the way, there was comparison between PVI and AV node ablation and bi-V pacing. And if you look, so that's the ultimate rate control strategy. If you look at ejection fraction, the ejection fraction really improved in the PVI arm as compared to the AV node ablation and bi-V pacing arm. Even the heart failure parameters improved remarkably for PVI versus AV node ablation and bi-V pacing, including the 6-minute walk test and the living with heart failure questionnaire. So one of the criticism of this trial is, why was the PVI compared to an AV node ablation and bi-V pacing? And the investigator said, well, the antiarrhythmic versus rate control has never been shown to be any different. So they took the approach, what a lot of people would take in patients with low EF, is just to ablate the node and do bi-V pacing. But then obviously the second trial after this looked at ablation versus amiodarone for the treatment of persistent AFib in patients with CHF and an implanted device. So all these patients were low ejection fraction, had already defibrillators in place. So it's a different population than the first group of patients that I've showed you. And if you look at the outcome, which the primary endpoint of the study was freedom from AT or AF. And catheter ablation outperformed amiodarone in a statistically significant matter, 70% or versus around 50% with drugs maintaining sinus rhythm. And if you look at the change in LVEF and heart failure parameters, just dividing these groups in patients who had no recurrence versus recurrence, there was improvement in EF, improvement in the 6-minute walk test, and improvement in the heart failure questionnaire as compared in the group who had recurrence. That's both in the antiarrhythmic and in the ablation group. But this trial had an interesting secondary endpoint. The secondary endpoint, we're looking at mortality and unplanned hospitalization. And if you look at unplanned hospitalization, there's a strong reduction, 58 to 31%, and mortality was significantly reduced. So some people criticize the study. This is secondary analysis. The trial was not designed to look at mortality. So that explained the next trial, which is the CASTLE-AF trial that was recently published a few months ago in New England Journal of Medicine, looking at catheter ablation for AFib with heart failure. And the people included in this trial were patients with ejection fraction less than 35. All these patients had devices, had dual chamber ICD, had CRT, so they had the ability to monitor for AFib recurrence on a continuous basis. And if you look at the primary endpoint, you can see that there was significant reduction, 44.6% versus 28.5%. So 38% reduction in primary endpoint, 47% reduction in mortality, 44% reduction in heart failure hospitalization, and 51% reduction in cardiovascular death. And if you look at these endpoint in these Kaplan-Meier curves, you can see that ablation as compared to medical therapy reduced death or hospitalization for worsening heart failure, reduced death from any cause, and reduced hospitalization for worsening heart failure. Obviously, there was some criticism for this trial. They screened 3,000 patients and enrolled 363, so there's possible selection bias. But the most reason for excluding these patients were patients needed to have either were intolerant to amiodarone or failed amiodarone or had side effects from amiodarone. And there was a high mortality in the control group, and some people question whether these patients were on good medical therapy. But if you look at the medication in both groups, the percentage of patients who were on beta blockers and were more than 90%, the percentage of patients who were on ACE inhibitor, ARB, were also more than 90%. And looking at the AFib burden during follow-up, if you start with an AFib burden of 51%, so you spend 50% of your time in AFib, by 60 months after the ablation, the burden dropped to 27%. If you were on drugs, burden increased from 50 to 64. So I think one important point in this trial is that, you know, maybe we shouldn't aim, or it's not necessary to have 100% elimination of AFib. Simply 50% reduction in burden translated into mortality reduction and hospitalization reduction. So, but of course there were the criticism, and again, Milton Packer, as he did with Cabana, published this editorial in MedPage. It says, where are all the cynics when we need them? And basically trashed the trial, said it's a small trial, selection bias, underpowered trial. But I think, to be fair for this trial, this was a randomized trial, and the intention to treat analysis was applied to look at the results. And despite the small number of patients, there was reduction in mortality and reduction in hospitalization. This is the last trial that I will show you, but I think this is a very interesting study. Most of the prior studies looking at AFib ablation included a heterogeneous group of patients. So these patients could have ischemic heart disease, valvular heart disease, etc. But the camera MRI study simply took patients with dilated cardiomyopathy and persistent atrial fibrillation and did MRI on all these patients. And they divided these patients into patients who have scar, as evidenced by delayed gadolinium enhancement, or absence of scar, just dilated cardiomyopathy without scar. And the way they did an ablation, they basically isolated the vein and isolated the posterior wall. This was a different set of patients, long-standing persistent atrial fibrillation, difficult group of patients. And if you look at ejection fraction improvement in the catheter ablation group was 18%, and the next group of patients underwent medical rate control. There was only 4% improvement in ejection fraction. And if you further stratify these patients by patients who had scar on MRI versus no scar on MRI, then you see that the improvement in ejection fraction was good in both, but it was, if you had negative delayed gadolinium enhancement, the improvement in EF was 22%. So that's probably even better than CRT, unless you're a super responder to CRT, but the improvement in ejection fraction was really impressive. And as this slide shows, the higher the scar burden, the lower the change in your ejection fraction. So in people who had no scar burden, some absolute change in EF was up to 45%. So in conclusion, AFib ablation improves quality of life and reduces cardiovascular hospitalization as compared to medical therapy. At this point of time, we cannot say that AFib ablation has any survival benefit. But as I mentioned, we really offer AFib ablation to treat symptoms. However, that subgroup of patients that we used to shy away from ablating, the heart failure patient, there's growing evidence that rhythm control of AF in heart failure patient with catheter ablation has particular benefit. Survival benefit is possible. The few trials that I showed you saw some survival benefit, but improvement in ejection fraction is key. Every single trial of ablation in heart failure patients led to improvement in ejection fraction. And I think patient selection is key. You can't wait till the left atrium is 6 or 7 centimeters. By that time, probably ablation is not going to work. You probably have to ablate sooner. And maybe there's more benefit in patients who have strictly dilated cardiomyopathy, no scar, no other etiology of their heart failure. And maybe the AFib is what's leading to heart failure. And with that, I close. Thank you.
Thanks, Michael. We're open for questions if folks have any. I can start out. So if you have, if we embrace this latest data about heart failure and the huge number of patients on heart failure, and 50% will eventually develop AFib, that's a huge number of patients to undergo ablation. And obviously good news for EP if you want to do that, but I guess I just want to ask, so if we have, you know, someone in heart failure, what is the duration of time? Because we have a lot of patients that have been in AFib for a long time, right, that we've been doing rhythm management, rate management on. You know, what's sort of the time threshold for recent versus chronic that we should think about referring?
So I think that's a good point. The long-standing persistent definition is any AFib that's been persistent for more than 1 year. This is the group of patients that's really extremely tough to manage. So I think the first patient that will approach for ablation are patients who have paroxysmal AFib or somehow persistent atrial fibrillation. Every now and then you have to cardiovert them or you have to put them on amiodarone. I think this group of patients will probably benefit from an ablation, especially if the etiology of their cardiomyopathy is dilated cardiomyopathy without any prior infarct or scar from a valve surgery or what have you. In terms of the long-standing persistent, I think if the left atrial size is still around 5 or less than 5, if you don't have any good explanation for the low ejection fraction, and if they're very symptomatic, they will deserve a chance of being ablated. But if you have a left atrium of 6 or 6.5 centimeter, and if their EF is 10% and their LV is already 8 centimeter, probably it's too late to do an ablation.
It looked like that the latest data you had about the scar and the importance of the scar, is that a reasonable thing, or is just not enough data to decide at this point about using that as a marker for who might be successfully ablated?
So, you know, the data that I showed is a very small trial, around 60 or 80 patients, but at least I think it's a thought for looking at your patients when you're not sure what you want to do. Their EF is 30%. You have no good reason why all of a sudden they've had low EF, but you see that high burden of atrial fibrillation. And if you're on the edge of sending them to an ablation or not, maybe risk stratifying them with an MRI, and if you don't see scar or the percentage of scar is very low, they might benefit from an ablation. But the study is very small, but it's definitely thought-provoking.
Now, is that, I have a question, but is that that mid-wall scar on MRI is a signal for cardiomyopathy, not ischemic?
Yeah, it's not-
and so does this mean that ischemic cardiomyopathy would be more likely to benefit than non-ischemic?
No, I think the way I would look at this is if you have no scar whatsoever, then you're more likely to benefit. And I think always ischemic cardiomyopathy are less likely to benefit from the ablation because you will have definite scar. The difference is that the scar in an ischemic is in a coronary artery distribution, but the scar in dilated cardiomyopathy does not have to be in a coronary artery.
So my real question, my other question is, and I ask this every time with a talk about atrial fib. So you say that you tell the patient, I'm going to do this for your symptoms. I'm not going to stop your anticoagulation. But I'm aware of many patients who stop their anticoagulation and many patients who want to have this done to stop the anticoagulation. So you say, so let's take the situation of a patient who insists on stopping the anticoagulation. Their CHAD score is 2 or 3 or something like that. They stay in sinus rhythm, best you can tell, all the time. The reason for the continued anticoagulation, I know, is the overall studies show that they still, this group as a whole, continue to have strokes. Are there people in that group who don't continue to have strokes, in whom the anticoagulation is really is not helping? And if recurrent atrial fib is the concern, are the technologists to know that? And if recurrent atrial fib is not the concern, what is the mechanism of stroke in a high CHAD score patient that does not have recurrent atrial fib?
That's a good question, but so just to answer the first part, right now we don't recommend an ablation as simply an alternative to anticoagulation, so just to put this aside. But the mechanism of stroke in atrial fibrillation is not only the presence of AFib and clot formation in the appendage. There's many studies that shown actually that stroke does not cluster at the time of occurring of atrial fibrillation. So if you have pacemakers or implantable loop recorder and it shows high burden AFib, the clot doesn't necessarily have to occur at the time when the AFib occur or 48 hours after. That's definitely a high risk period, but a lot of strokes do not cluster at the same time of atrial fibrillation. And there's been studies that showed that atrial fibrillation, the presence of AFib is associated with marker of, high marker of endothelial dysfunction, marker of increased thrombogenicity. So not only the CHAD-VAS score, the CHAD-VAS score is the best thing we have to predict the risk of stroke. But we don't have anything else that would predict if these patients are at high risk of stroke right now other than the CHAD-VAS score.
For people with a high CHAD-VAS score who've never had atrial fib, also at risk?
Yeah, I mean, there's studies that showed if you have diabetes, hypertension, your stroke risk is higher. So there must be something else other than the AFib.
If you get a high CHAD-VAS score by being old and being a male.
Yeah, and your risk of stroke will be higher.
So should every old person take anticoagulation?
No, because it's eventually, it's eventually risk-benefit ratio. If we don't know exactly what your stroke risk would be if you have high CHAD-VAS score but no AFib.
Great talk, Mikhael. Thank you very much. Question for you: with the studies that showed mortality benefit, was the mortality benefit in ablation arm, could it have been related to an imbalance in drug use and medication use? So antiarrhythmic would be more toxic in patients who were in the control arm. Would that looked at in the trials?
That's definitely criticism, but even if you look at the CASTLE-AF trial, for example, there's similar percentage. The CASTLE-AF trial included 30% of patients who went rhythm control and 70% who went rate control. And the percentage of people on antiarrhythmic was the same between the two groups. So that's unlikely. In addition, most of these patients had dual chamber ICDs or CRT. So the arrhythmic death that you see with antiarrhythmic drug is probably unlikely to happen. But I think the biggest reason not to believe this is the case is that the percentage of patients on antiarrhythmic drugs end up being the same between the ablation versus medical therapy group.
So it is very hard to stop anticoagulants in somebody who's ever had atrial fibrillation, even though you ablate them or whatever. Number one. Number two, I mean, is that subendocardial scar, subepicardial scar? Is that ischemia? Is that sarcoid, or what is that?
No, I think you see a lot of scar in patients with dilated cardiomyopathy.
You do.
It could be sarcoid, but most of the dilated cardiomyopathy scars revolve around the valve. It's in a perivalvular area.
But it's really hard to separate that out.
Yeah.
Then when you use as a category congestive heart failure, you don't ever say that term in front of a patient. You'll just scare the daylights out of them. Number one. Number two, when you try to define this group, it's very difficult to define. And when somebody comes into your office and they are said to have congestive heart failure, then your work is beginning, trying to find out the etiology of it. Well, this has got them all mixed in together. How about aortic stenosis in that group? So it's such a diverse group to try to draw conclusions when you have that as a base is, to me, is very difficult.
So, I mean, if you're talking about the study, that strictly took dilated cardiomyopathy. So it excluded valvular disease, excluded ischemic, excluded just simply the etiology of cardiomyopathy was unknown. The only thing we know on these patients is that they had low EF and persistent AFib, and no other etiology of cardiomyopathy. So this particular study just simply included dilated cardiomyopathy, no known cause of low EF. The other trials, yeah, obviously they included a heterogeneous group of patients, including the CASTLE-AF, including the ischemic, valvular, but the camera MRI study strictly included dilated cardiomyopathy patients.
The Milton Packer comment on the Cabana trial is very, very strong, and it talks about how the trial was actually designed with the idea that there would be a 25 to 30% crossover. It's a very, very strong comment. So looking at that, and it's out there, could you comment a little bit on the risk of the procedure? And if you had a very, very serious complication from the procedure, what things in advance do you go through as far as reaching a shared decision with a patient about whether they should have this procedure or not?
That's a good question. So AFib ablation, like any other procedure, has risk. And if you look at the guidelines, under the AFib ablation is a class 1 or 2A indication. Under it says the clear risk-benefit of this procedure should be explained to patients. And we, in our clinic, we give patients a brochure about AFib ablation or different AFib treatment that include all the complications of atrial fibrillation. Obviously, the complication that everyone fears is atrioesophageal fistula. And in the Cabana trial, which was the largest ablation trial, included more than 2,000 patients, there was one atrioesophageal fistula, so 1 in 2,000. And really, this complication occurs mostly in patients who ablate, with physicians who ablate a lot on the posterior wall, because that's where the esophagus lies. So that's the most common or the most feared complication. Luckily, it seems to be very uncommon, 1 in 2,000. I mean, that's a low risk. The others are pericardial effusion, tamponade. There's also risk of stroke. So all these are explained to patients. If you look at Cabana, the risk was extremely low. I don't have the exact number, but 1 atrioesophageal fistula, I think there were like 8 tamponade out of 2,000 patients. So that's overall comparable to any device treatment, any regular ablation. So the risk has become low with the new technology. But you're right, when we talk to patients about AFib ablations, we clearly should explain to them the risk and the benefit. And I'm sure you've seen them. I mean, I know a patient who comes to the COA at Midtown every 4 months for a cardioversion. And he doesn't want to have an ablation. But he's so symptomatic in AFib that he cannot stay in AFib more than 24, 48 hours. If you're offering ablation to such patients who are extremely symptomatic, then that's reasonable if you fail medical therapy. I think it's when you start offering ablation without trying medication, offering ablation to borderline symptomatic patients is when it becomes too much. And that was some of the comments to Milton Packer. He said the greedy electrophysiologist ablating, all AFib. But I think that's a good point to bring.
Thanks so much. That was really fantastic. That was great.
The preceding program is copyrighted by Emory University.